I'm Dr. Mark Gold, and this is the Gold Standard. I'm really excited to have this conversation today with Kevin Hill. Kevin is probably the expert in the United States, at least, if not globally, on cannabis and cannabis use from the clinical point of view. Let me just start with saying, hi, welcome. And tell me a little bit, like, how does that happen? How do you go from being a pre-med to being a world-class cannabis expert?
Great. Thanks for having me, Mark. First of all, I just want to say thanks for having me be a part of this great series. So I've been interested in cannabis for probably 15 years or so, and I think I got most interested in it once I started doing intakes, seeing new patients in the partial hospital program at McLean, where I did some training. And what I found was, as most of those patients were struggling with problems with alcohol or opioids, when I would sit with them and take a careful history, I would find that probably 60% of them described using cannabis daily for years, usually in their late teens or early 20s. And so the gears started turning at that point, and I started to wonder, what if you were able to intervene at that point with a treatment or a combination of treatments that actually worked? Would you see as many of those people down the road coming in to a program like ours for alcohol or opioid problems? And so that kind of got me going. And from there, I started doing some research trying to develop medications mostly for people who had cannabis use disorders. As we'll probably talk about, there's a subset of cannabis users that actually develop an addiction. And, from there, from my early trials and developing treatments for cannabis use disorder, all of the laws have kind of taken over, right? So most states have medical cannabis or legalized recreational cannabis. And so things have sort of snowballed. There's been a tremendous interest in it. And I've tried to hold tight to really focusing on where the evidence is. And that creates, an interesting position for somebody like me.
It's funny. So when I was at Yale, cocaine was considered safe and non-addicting and wasn't in the DSM. There was no such thing as cocaine use disorder in the DSM, either the research diagnostic criteria, the original DSM, the DSM-2, the DSM-3. I mean, you were in the same position at Harvard. There was no cannabis use disorder. So like, when did that hit?
Yeah, I think there was not as much talk about it, and I think one important thing that has changed recently really is that, if we were having this conversation 5 years ago, I would have said that most of the research indicates that about 10% of adult users of cannabis develop a cannabis use disorder. And so still is true that most people who use don't need to see somebody like you or me. But that percentage is going up. And
Definitely.
So now, if you look at the data, it's closer to 30%. I mean, there's, even some papers with numbers close to 35%. So in my mind, because of the increased potency, so there are some great groups around the country looking at the rising potency of cannabis over the years. And so that has gone up quite a bit in recent years. And so as a result, I think there's a greater percentage of adult users who are using cannabis that actually develop a cannabis use disorder. So things are, as more and more states have these policies, we're kind of dealing with the fallout. And that's why I think one of my foci is really trying to have informed consent, right? I'm not telling people what to do necessarily, but I want people to make smart decisions. If they want to think about using cannabinoids as a medical treatment, what are the pros and cons? If they're using it instead of alcohol, what are the pros and cons? And I believe that one of the major problems that we have with cannabis is that, and I do a lot of work with schools, as you know, if I go into a school and I've got 200 juniors and seniors and I quiz them on the harms of alcohol, they're going to do great. We talk about nicotine, they're going to do great, right? Doesn't mean that some kids aren't still using these substances, but we've done a very good job of educating kids about those substances. However, if I were to ask them about cannabis, the same group, they're not going to do very well. So because of, for a variety of reasons, including the sheer amount of money involved in this industry, there's a lot of misinformation out there. And I think that we really need to do better. Psychiatrists, general practitioners, everyone needs to be better informed so that they can have better conversations to provide real informed consent to patients who are interested. I think a lot of patients are interested in knowing where is the evidence. And I think that if they had better evidence and they felt solid, if they had better conversations with clinicians like you or me, I think they'd make better choices.
Well, it's just such an alarming number. I mean, just put on your hat as a board certified addiction psychiatrist and expert and say, of ever used, to have 35 or more percent develop a cannabis use disorder, that's pretty alarming.
Yeah, it is. It really is. And so you're touching on a lot of important talks, right? As we mentioned before, a lot of money involved in this debate. So there are a lot of very strong feelings. It's polarizing. There are a lot of people who have spent a lot of time and they feel that cannabis is harmless. They feel that it's a panacea of sorts for a host of medical treatments. There are other people who we know that we've collaborated with at times. They are strongly against cannabis and they won't entertain even conversations about cannabis with their patients sometimes. And so I believe the answers are somewhere in the middle. But I think as you're saying, if we're looking at the evidence, things are getting worse, right? Cannabis is stronger than it has ever been. And
well, let's spend the time on that. So
yeah,
basically, like sometime down the road, we'll get a conversation with David Smith, who used to run Rock Doctors and went to Woodstock and would take people's cannabis and analyze it. And he told me in the past when I spoke out there at Haight-Ashbury that in the 60s, the average cannabis cigarette was 0.5% THC, that he didn't find even 1% THC at Woodstock 1. Mm-hmm. So, like, to put the historical use, this isn't your grandfather's cannabis.
Yeah, absolutely not. So, a colleague of mine that I've worked with before, Mahmoud El-Soli, who's from University of Mississippi, his group has done a lot of this work, which is really important. And so you're talking about Woodstock, perhaps a little after Woodstock, 70s, 80s, average THC content, 3 or 4%. Now, so Dr. El-Soli's group has published a series of papers, and the latest really puts the average THC content at around 20%, 19 or 20%. But if you were to go, if the viewers were to go to a dispensary locally or a cannabis store, you can easily get flower at 20 or 30%, so it's much, much stronger than it used to be. And I see this manifested really in a couple of ways. When I talk to families, they will say usually one of two things. They'll say, well, we knew our son was using with his friends, but we did that too, and we turned out okay. Or they may say, look, we knew our daughter was smoking at night in her room, but we're glad she's not using fentanyl. And so both of those statements has, you can understand why they might feel that way, but it's important for people to understand that as we're learning more and more about this stronger cannabis, the harms of it are becoming more precise. So, we're learning more. I mean, we can just, there's so many things, more cardiac problems. Dr. Gold and we collaborated on a paper came out in 2021. So the psychiatric harms are very, very clear. We're going to have a bunch of psychiatrists listening to this. And so that paper came out in American Journal of Psychiatry at the end of 2021. But in addition to that, like I said, cardiac problems, perinatal issues. So clearly, those that are interested in becoming, women that are interested in becoming pregnant, they have to consider the harms of cannabis. Sperm morphology. So fertility for men is something that we're learning more. Papers continue to come out. So head and neck cancer was another one recently. So I think that these are all very alarming things. And again, people may still choose to use, but they need to be aware of what these risks are.
So the question about risks, I heard Sir Robin Davies, I guess in the who you probably know and we all follow. And one of his main charts is really the potency of cannabis and the number of cases of schizophrenia.
Sure.
Like with this audience of psychiatrists, the question is, do you and your fellow Harvard experts think this association is real and important?
Oh,
And
absolutely. So again, I give a lot of talks to various groups, and I have a slide where we talk about the harms of chronic cannabis use. And one of the points that I try to make is that the dose, as we've talked about already, dose really matters. So these are dose dependent issues mostly. But in that slide, we talk about things like increased, worsening anxiety, worsening depression, increased suicidal ideation. And at the bottom of that slide is psychosis. And to me, of all of those associations, the association, so those patients, people who have a family history of a psychotic disorder, schizophrenia, schizoaffective disorder, bipolar disorder with psychotic features, if they begin using cannabis, they're probably 1.5 to 5 times, depending on those studies that you mentioned. And there are many studies. So there's a strong association. So to me, again, if I'm talking to high school students, that's probably, it could be the most important thing. So if you have a family history, your risk is different. The stakes are really high. And another thing, Mark, as you know, is that unfortunately, we get asked to see patients on inpatient units at times, and they're psychotic, right? You can have a transient psychosis, hopefully, but a lot of times folks trigger a psychosis that is going to be a permanent psychosis, and you can treat it, but unfortunately, the course of that illness is very sad, unfortunately. So I've had to talk with many parents, and they've asked me, if our child didn't use cannabis, would this have happened? And we don't know that. There could be other things that could have triggered it or not. But unfortunately, like you mentioned, the data out of the UK, very, very clear.
Very strong.
That there is a very strong association, and we can't avoid that. We have to, young people need to know the risks of cannabis, especially if they have a family history of psychosis.
So, you bring up a special point here, and that is that the psychosis that's produced by the interaction, of the host and this high potency cannabis is maybe even worse than naturally occurring psychosis from the point of view that our treatments don't seem to work as well.
Yeah, I mean, I think we've seen that in a variety of ways. There are many people right now in a variety of medical disciplines that are feeling the effects of these cannabis-related illnesses. Another example, cannabis hyperemesis syndrome. So,
Definitely.
10 years ago, we would see some cases, but not very many. And now, I must say, I must say, our emergency colleagues are very skilled, but we don't have great treatments for this. And so people come in and they may get treated symptomatically, but also with things like Haldol or capsaicin. But this has become more challenging because of the potency. And I have patients in my clinic that have had numerous ED visits related to this, and these are smart people, and they will often try to rationalize their use. Well, I exercised a lot that day, and then I used, and I end up in the ER. So if I don't do that, it won't happen. Or if I stay away from these particular strains, it won't happen. And it's not so simple, unfortunately. And so if you are using strong cannabis in a chronic way, you're just opening the door to a host of problems that are very difficult to treat. And we've talked about a couple now, psychosis for sure. Cannabis hyperemesis is also one on that list. So again, it gets back to things are different now. The potency is much, much stronger. And so we're feeling the negative impacts of that increased potency.
So, and we have younger initiation of use and more frequent use. Um, so it's a mess out there. And is all of this in your mind like within the last 5 years?
Well, I think we've had medical cannabis in the United States since 1996. We've had it in Massachusetts since 2012. I think the momentum, as you're alluding to, the momentum's picking up, right? Like so, in 2012, Massachusetts was among the first states, as those of who are tuning in may know, we're kind of a liberal state, and so people wanted to have access to cannabis, and so we were at the fore. I think one of the early adopters, but now most states have it in one form or another. So yeah, I would say that the last 5 years have been particularly
Yeah.
challenging because most states have these policies now.
So, but there's nothing that you can say, oh, this changed in the last 5 years. It's just momentum.
Yeah, it's momentum. I think that, and so this is one of the things that I've said for many years related to these policies, right? Whether or not you agree with the policies, whether or not you agree with legalization or medical cannabis, I have always encouraged folks on both sides of the debate to stay involved, whether or not the vote, because what happens is the pro side fights against the anti side, they vote, and then one side wins. Most of the time, the pro side wins, but then the anti cannabis folks sort of back down, and then they're not involved in the policies that get implemented, and the policies are weaker. So
I understand.
wherever you are on those policies, I think you need to stay engaged in your local community with policymaking so that we can mitigate the risk, right? I think that that's what we've had in these states, right? People want access to cannabis. How do we give people what they want while mitigating the risk? To me, that's been the big question for years.
Well, to me, the big question was, since when do people vote on whether something is a medicine?
That's a whole nother debate, and unfortunately, actually, we published a paper in 2022 on whether or not, as I mentioned, right, like California started this in 1996, and so one of I worked with a group at University of Maryland, David Gorelick, and his
Yeah.
colleagues. Are those medical cannabis policies becoming more tightly tied into science, as you would hope? And the answer is no,
No,
unfortunately. Yeah,
no,
they
it's
have
not.
they
It's ridiculous. So, like if you would have had recreational cannabis circa Woodstock one, we wouldn't be having this discussion.
True. No, that's true. I think that because of the combination of the policies and the potency has put us in a very difficult
Yeah,
predicament.
the
And
FDA would never approve uh, the high dose THC because
yeah,
what would they approve it for? Like if you were to compare an FDA approval for ketamine, we have esketamine approved. Here we have
mhm.
like it's hard for people to believe that the FDA would approve it, but it's absolutely safe and effective and life saving. Like
Mhm.
what's a comparable for THC?
Yeah, I mean, I think so. There are three cannabinoids that are FDA approved: dronabinol, which is pure THC; nabilone, which is a cannabinoid 1 agonist; and then CBD, cannabidiol. But I should also always want to point out that the CBD that people are using out there is not the FDA approved form. To get to your question, dronabinol is the closest to the cannabis, but it's not very close to what people are using. Again, the potency, the lack of purity. I mean, there's so many complicating factors. And again, as you say, Mark, the FDA is maligned at times, but I think they do a good job overall trying to protect people. And that's why, for me, I mean, I'm open to talking to patients. I mean, we have a cannabinoid clinic here at Beth Israel, and I may talk with somebody about using cannabinoids to treat pain, maybe as a third line treatment. But when we do that, we're talking about, can we use FDA approved cannabinoids? We're not talking about a medical cannabis certificate. If somebody wants that, we can send them to somebody that can do that. But yeah, I think it is an issue that unfortunately most of the cannabis and cannabinoid use that occurs in the United States is not under the protections of the FDA, unfortunately, and that's a problem.
Right. Well, the FDA does look at the evidence, weighs evidence, has standards for clinical trials. And I've always thought that you're the best of breed here. Like when you talk about cannabis for pain, you're always saying, well, we've already exhausted the FDA approved pain medicines. And so our algorithm or decision tree for use has cannabis, and you just said third line.
Yeah. So Mark, I'll take this opportunity. So there was a paper that we just published that came out last Friday, actually, in the Annals of Internal Medicine. So the American College of Physicians, allowed me to work with them, and we collaborated on a paper that they call best practice advice, and we address these issues. So, what should happen if somebody's interested, a patient is interested in cannabis for chronic non-cancer pain? What should a doctor do? And so we
Right.
cover a lot of these areas in the paper. I think number one, we want to have a sensible evidence-based conversation. What are the pros and cons? What are the expectations that a patient may have? What have they already tried? So
Right.
as you were saying, Mark, for me, I want somebody to work with their physician and try to exhaust all of the evidence-based options, and then possibly FDA-approved cannabinoids. Some key areas that we touched on in that paper that just came out are really, we're emphasizing the areas of harm too, right? Like there are certain groups.
Right.
We talked about the American Journal of Psychiatry paper. So in the Annals paper, we say people with substance use disorders, people
Sure.
with psychiatric illness, people who are pregnant or breastfeeding. These are groups that we want to stay away from cannabis for chronic non-cancer pain. And importantly, I think we make the important distinction where we come out pretty clearly and say that you should avoid inhaled cannabis products, right? You shouldn't be smoking medication. So I think we want, there is a tremendous desire from patients and clinicians for guidance. And hopefully people will read that Annals paper and that will provide some of that guidance. But you're absolutely right. I'm open to talking to patients. People are desperate. They want to treat their pain. But is this the best way to do it is really the question. And another important question, how much evidence should you have before you try something clinically? I think one thing that I think has been backwards in a lot of cases is that, there are cannabinoids out there that you'll hear about and people say, oh, it's great for this or it's great for that. And there really isn't much science backing that. And to me, I would not want my patients to do that if there were other options, right? And so to me, I want better evidence, and we can talk about why the evidence has lagged behind the interest, but I think that there needs to be solid evidence before you choose something as a medication. Are there better treatments that have better evidence? That's a question that is going to come up with any cannabinoid, really.
Yeah, no, I like that paper, as you could tell. I mean, and
Thanks.
also the American Psychiatric Association really, that was a commission, like the council asked us to put a group together and look at what the evidence was for the use of cannabis in psychiatry. And we couldn't find much, but you could find it for pain.
Yeah,
And we should talk
not
about
much,
that.
right? I mean, there is not much evidence there. So I think that, in the world, so we mentioned there are 3 FDA approved cannabinoids in the United States. There's another cannabinoid combination product called nabiximols that is available in the UK and some other places around the world. And for that's probably the closest pharmaceutical grade compound to cannabis. And for that compound, there is moderate quality evidence that it provides a small amount of benefit for chronic non-cancer pain. That's about as good as we can do. And so I think it's important to point that out, right? So it might provide a small amount of benefit, but what are the risks? There often are a lot of risks here. So it's a risk-benefit conversation. We also pointed out that currently, despite what some people believe, there really is not evidence to support the use of cannabidiol for pain at this point. So again, if evidence comes out, I'm willing to change my mind for sure, but we want good evidence. And I think that's one of the beauties. And the last plug I'll put in for the paper was, one of the co-authors, or actually a co-first author on the paper, Devin Can-Sagara, he works with his colleagues for the AHRQ, the Agency for Healthcare Research and Quality, and they have a living, I'm trying to think of like a living database, more or less, of cannabis clinical trials. So, there are places where if you're interested in the evidence, you can go, and the Annals paper reviews some of that, but there are a lot of groups that are really interested in knowing exactly where the level of evidence is currently.
But again, the changes in regulations and access and potency all preceded evidence.
Yeah, definitely. I mean, I think that the interest in it, the policies have not been tightly correlated with the evidence, unfortunately. One of the things that I've said for years is that the interest is ahead of the evidence, unfortunately, in this area. So I wish it weren't that way, but that's kind of where we are. And I think that sort of begs the question, what groups should be contributing to the science, right? I think that people who are benefiting, companies who are selling these products, states like mine that are having tax revenues come in as a result of selling cannabis, they should be contributing more to the evidence-based, and they haven't, unfortunately. So
there's no incentive to that.
True,
but
absolutely.
This is kind of off the subject, but you might find it interesting. I've been discussing with national experts the kind of California sober approach to post-addiction treatment.
Mm-hmm.
And however odd this may seem, some have suggested that it might not be so bad for patients to smoke cannabis rather than the traditional approach to addiction treatment, which might be a McLean approach or a Betty Ford approach, which is detoxification, medication-assisted treatment, and kind of long-term community-based AA, NA, and so forth, which has the best outcomes, or at least the only reported outcomes. And in that case, you can hear even some addiction experts talk about smoked cannabis as an alternative to the traditional approach. Like, how is that coming about without them asking experts like you?
Well, I mean, there are a lot of people that call themselves experts. So, as we've alluded to a few times, I'm not going to take away, a lot of people have a lot of lived experience in these areas, and that's valuable too. But I think you have to decide what is most important. When you're listening to somebody talk about these issues, I think you have to understand the difference, to me, between peer-reviewed science and other things, right? There are a lot of experts who are prolific and putting out blogs and all kinds of, social media and other, writing books and things on cannabis, and they're not producing any peer-reviewed science, unfortunately. And so I have nothing against, I've written some books too, right? I have nothing against that, but I think that you have to understand that peer-reviewed science is really what we should be basing this all on when we can, right? And I think that we do have science for cannabis, and papers like the ones we've talked about. And so I wish it were different. I wish people would try to use more science and talk to people who are more evidence-based. But that's, again, like you said, talk about incentives, right? If you're a cannabis company and you can talk to somebody who may be affiliated with a big name institution, they may or may not have, again, this happens a lot where they haven't done any science really. but they're affiliated maybe as a clinician, and that's good enough, right? You get them as write a testimonial or say a good few things on their blog or LinkedIn, and now you're selling products.
Yeah, no, this has kind of turned into even a debate among celebrities, with the celebrities who are in NA and Elton John, and well, I'll leave that for now. But one other contribution that you've made that the audience may not recognize is you've talked about how important it is to be able to talk to your patient about cannabis, how important it is
Absolutely.
to get a history of use, and how their cannabis use might affect the other medications they're taking in
Mhm.
interactions. You've reported that. I think you have a really high impact publication in that area, as well as just the general idea that cannabis use could interfere with other medications or other treatments.
Yeah,
And,
definitely.
and
So
anesthesia, and
yeah,
anesthesia.
yeah, no, yeah. So I'm working with some folks in anesthesiology here, and we've written some papers along those lines too. So I totally agree with what you're saying, that I think that we have to be able to have sensible conversations with our patients, right? As an addiction psychiatrist, one of the things I say is that part of my job is to try to get people to do things they don't want to do. And part of that is understanding that there's going to be differences of opinion, right? And so I frequently will say to a patient, look, we both want the same thing. We might have different ideas about how to get there. And so a part of that is being willing to have differences of opinion. And, we're still going to work together. We're still trying to do the same thing, but I have to be willing to be flexible at times. And so I think having that flexibility, being able to talk about things where people have different opinions, that creates an opportunity, right? Because what happens is when you're treating somebody with a substance use disorder, a psychiatric disorder, they may often not want to do what I think they should do right away. But if things are not going well for them, then they're going to come back to that topic and say, well, you know what? Dr. Hill said I should do this. And I didn't want to do it a few weeks ago, but maybe I should do that now. And if they really believe that you're invested in them, that you really want what's best for them, and you're willing to make multiple efforts to try to help them, they're going to ultimately more than likely come around and be willing to try treatments that they would not otherwise have tried, that they didn't want to do right away. So I think with cannabis, it's a great example of that, right? Like, I am not advocating for my patients to use cannabis in most instances, but I'm willing to talk with them about it. I know the evidence, and you mentioned earlier, right? Like, I wrote a paper over a decade ago that showed that cannabis use did not affect treatment outcome in adolescents getting treatment for opioid use disorder, and I would not have expected that. But my point is, you have to be willing to have differences of opinion in the office, and then while you're still working together, to have a chance for somebody to come around and try things that they didn't want to do right away. So I'm a big believer in that. I think that's a great metaphor, really, in the world at this point, right? Like, just because somebody has different ideas with certain, whether it's politics or religion, I mean, we have to be willing. There's still a good person, right? We may not agree on all these things. And I think that in the office, working with patients, I think is it's a great place that sort of exemplifies the tolerance that you need to have for differences of opinion if you want to be successful, right? I can just say, if I said, why are you doing this? You should not be doing this. Look at all these papers. I'm not going to get anywhere, and people aren't going to want to come back. But I think
Well, I
where I've
mean, I think you've been great at that. But to go back to maybe get some pearls out of you here for the audience.
Sure.
When someone is anticipating surgery, why is it important for their anesthesiologist to know about their cannabis use? And what's your advice?
Yeah, so great. So Mark mentioned, you mentioned that, we've published some papers looking at the fact that more and more people are presenting for surgery and they're using cannabis, and it does affect the anesthesia that they get. Another related issue gets back to drug-drug interactions. And so the paper that we published in 2021 in the Journal of General Internal Medicine showed that cannabidiol has a lot of drug-drug interactions. So we have to understand that cannabis, whole plant cannabis, or cannabinoids like CBD, they have the potential, there's potential benefit in some cases, but there are potential risks. And so people need to be talking to their doctor. If you're using these compounds, if you're using cannabis or you're using CBD that you get online or at a store, your doctor needs to know about it so that they can make the best management choices, whether chronically, the medicines I might prescribe, or acutely if you're going to have a procedure. So I think that as more and more people are using stronger cannabis is another example of how doctors beyond psychiatrists really need to be aware of the potential impact of that cannabis use.
So I'll change gears one more time. The good news about this chat is it has to be obvious how much you've contributed to the field. And all these different areas are evidence-based that people can look up and they can say, this is what we've found, meaning that you found this, and it's relevant to everyday life. And another area of contribution, and I did this myself in the 70s. I worked for then a doctor, a cardiologist who became the commissioner of baseball, and worked a little bit with professional athletes. And at that time, the challenging drug was cocaine. Defensive ends had cocaine issues, but it, in some sense, was seen by them as performance enhancing until it wasn't. And you've become an expert in this area. Could you just maybe go through what are the current conundrums in dealing with professional athletes and how you've handled that?
Yep. So my roles are really twofold primarily. So number one, I've helped some of these leagues with policy related issues. So I am the co-chair with Dr. Jeffrey Ling, who's a neurologist at Hopkins. I'm co-chair of the NFL Pain Management Committee. So that committee is really aimed at trying to provide the best information to NFL clinicians and the players when they're making decisions about how to treat their pain. And so we've taken some steps there. We've developed a prescription drug monitoring program. So again, trying to be evidence-based about that. I also treat athletes from all four of the major sports. Not a lot. I mean, I think that one important thing, talk about conundrums, testing has become less frequent over the years. And I don't think necessarily that's a good thing because ultimately what I want when I'm thinking about any population, I want people who need help to get help. And I think that, I understand that people don't want to be tested. But my worry is that, these athletes are sometimes not getting the help that they need because they're not getting tested much. So these days it's harder for somebody to get on the radar, but if they do, they are sent to somebody like me and, we'll do our best to try to help them. But a lot of that treatment really is not mandated, unfortunately. So that becomes hard. I think one other thing I want to mention with the athletes, which is a major issue that we're trying to deal with, is really the question of cannabis versus alcohol. And so there are many athletes that believe, if they're playing a baseball game and the game ends at 11 o'clock and they're just so amped up when the game ends, a lot of athletes believe that they need to either drink or use cannabis to wind down at the end of the day. And so that's something that we've seen in multiple sports, also at the college level. And so we're working on trying to do better with our messaging there. I think it's hard to tell them not to do something like that. And we try to trying to develop better alternative strategies for them. Certainly, there are a lot of behavioral things people can do to get to sleep, but that is a major issue. I think it's hard to, so many athletes use alcohol or use cannabis, and it's difficult to have people who've been successful
Sure.
go away from some of the habits that they've used along the way.
Well, I remember Major League Baseball being in locker rooms in the 70s, and I'm thinking in my mind, at least I remember a beer tap. I mean, having alcohol in the locker room. Would the half-life of alcohol versus cannabis be relevant to that post-drinking? And what's the effect of both of those drugs on sleep and sleep quality?
Yeah, great questions, Mark, as always. So I think that one thing that we have to recognize is what we do today, especially at night, affects what we do tomorrow, our ability to perform tomorrow. And so I think when we talk about alcohol, we talk about cannabis with athletes, we have to emphasize it. It may sound simple, but these are not performance enhancing substances.
Definitely.
Right? So even if it affects your reaction time the next day by just a small amount, that could be the difference, right? So many of us are fighting for jobs or trying to protect our livelihood in sport. And so any decrement, performance decrement may be really important. You mentioned sleep. Both alcohol and cannabis adversely affect sleep. So it may help you get to sleep, but both of those substances reduce the amount of time you spend in REM sleep. So they really are not great options for people to get to sleep. And so that's why I think so many sports teams are working with a lot of experts around to try to develop better behavioral routines to get to sleep, or maybe they'll use other things like tart cherry juice is one, that may promote some sleep. But the point is that we know the problems associated with alcohol and cannabis and sleep. And so those will not be the answers, unfortunately.
Yeah, so when I was doing this work, the cocaine issue, you talk about elite athletes, that cocaine was causing some problems for wide receivers. So the owners got that would make this association. They'd pick a guy and he'd have cocaine use disorder, and it would come up. They couldn't catch the ball like he did in college. Um, and you do see it was really not clear from the studying regular ordinary people. And I used to make the joke that if I was on cocaine, my tennis game would be just as bad because it's bad and I'm not an elite athlete. On the other hand, small changes in dopamine function for the elite dopamine functioning athlete could have devastating career effects because they're at the 99.9% function to begin with.
Yeah, it absolutely could. I mean, what we hear so often from athletes, they know their peers that have used substances for a long time and have not appeared to be affected. And so that's part of the challenge, right? I mean, there are, we could name names, right? There are people who are the top athletes,
Sure.
and everyone's tremendous, obviously, to get to those levels. But I do think that, not everyone are the all pro performers. And so for the rest of us, for people that aren't those elite players, the best of the best, because there are not so many of them, the margin for error is very small. And I think
Sure.
that's really the message, but it's a hard message, right? Everybody wants to believe that they're the best. So I think that we need to work, like I know I need to work on that messaging, and it's a work in progress. And I'm working with colleagues around the country and in other countries to try to do a better job, because I want to bring that science to the athletes. And I think how you do it, that messaging is critical. And so again, there's room for improvement there, and I'm hopeful that we can do a better job moving forward with that.
All right, I'm gonna we'll close on something that is generally mainstream psychiatry, which is cannabis use disorder. So you already said increased potency, there's more cannabis use disorder, teen use, more cannabis use disorder. more frequent use than cannabis use disorder. But when I asked Chris Hammond at Hopkins, he says, yeah, well, that's an addiction for which we don't have either a treatment for overdose, which people object to the word cannabis overdose, but it's kind of a green out or vomiting syndrome. We don't have a Narcan. We don't have a medication assisted treatment, and we don't have a relapse prevention treatment. So in a way, the cannabis use disorder increases are giving us more and more chronic relapsing illness. Do you see that, number one? What are your approaches, number two? And how about like let's just see where that
Yeah,
goes.
yeah. So number one, am I seeing more cannabis use disorder? Absolutely. There's no question about it. I do think it's dose dependent. Number two, what do I do about it? I think many of the points, Mark, that you make are spot on. So we've talked about this earlier in the hour. No FDA approved medications for cannabis use disorder. So that's a weakness. But one thing the point I want to make, again, I treat this every day. And I am hopeful. When I get patients like this, I'm very hopeful because I know a lot of things about it, right? I know that there are multiple aspects of cannabis use disorder, right? So they're using cannabis in key spheres of their lives, right? Having negative impact on key spheres, work, school, and relationships. And I know that it's very unlikely that there are not other treatable problems in that patient, right? So there's often a co-occurring psychiatric disorder, anxiety, depression, et cetera, or a psychosocial issue related to those spheres that I mentioned. So I want to talk about their cannabis use. And so we've studied multiple medications, mixed results, as I mentioned, but also behavioral interventions. So cognitive behavioral therapy, right? I think that the data is very clear. You can use multiple types of psychotherapy for cannabis use disorder, depending on what you're comfortable with. And as long as you're doing it and people are engaged in it, they can do well. So to me, I think a multifaceted treatment plan that includes, number one, some type of psychotherapy aimed at why you're using cannabis, right? Because there's differences. If somebody's using first thing in the morning, it's different than using after work. So you have to address those areas. What are you trying to fill with that cannabis use? Number two, address the co-occurring disorders, right? They're depressed, treat the depression. It's probably not being treated now or not being treated appropriately. So if you do those things, I think, and number three, with cannabis withdrawal, if you address it, right? Like what are there symptoms, insomnia, anxiety, et cetera? If you address those issues with medication, usually, you have a chance. So I am very hopeful still.
Mm-hmm.
I mean, I feel like people have not had all of those areas addressed most of the time when they come to me. So if they're willing, I mean, we talk about evidence-based treatment plus patient readiness plus sort of the approach, the treatment approach, right? If I'm willing to make multiple efforts and the patient is ready and we bring evidence-based care, all those things come together, you can be successful. And I don't look at it any differently than any other substance use disorder. To me, and when someone's sitting across from me, I feel like I have a chance to do
That's
this.
great.
And I'm hopeful that we can do this. And so I've had a lot of success treating people with cannabis use disorder. It would be better if we had a medication that was FDA approved, but we still can successfully treat cannabis use disorder.
No doubt. I mean, we used to treat people with alcohol use disorder. The important advance that we had was we had a treatment for detox. Once we could safely detox people, then we could engage them and they could enter 12-step programs and so forth. Do you ever admit them to a hospital like, McLean or rehab for cannabis use, or do they have to have co-occurring?
Great question. So you're not going to be admitted for a detox from cannabis for sure. There are times when people, so you don't need an acute medical admission, but there are
That's for,
times.
that's maybe today. So like if the dose goes up more, I mean,
Yeah,
when
maybe we'll see that.
like
But
I was thinking about the history of detox,
yeah,
and we do have. If you were to tell me at Woodstock that there was going to be cannabis withdrawal syndrome, believe me, I would have found that ridiculous. And I was working in the Rock Doctor tent. I mean, like we had problems with psychosis from psychedelics. We didn't have like psychosis from cannabis. Like honestly, it was in controlled experiments, it was hard to even show an effect. I mean, there was like a famous holding your breath experiment compared
mhm.
to 0.5% THC. So like the whole world is turned upside down now. And I wonder what's the highest dose cannabis that you could buy and then self-administer and wonder what that looks like because that may be the future.
Yeah, it might be. I mean, so, we haven't talked about it during this conversation, but, concentrates, people can buy concentrated THC products with 80 to 90% THC. So I think that's important. Another clinical pearl when you're talking with patients about their cannabis use, you have to specifically ask them, are you using concentrates? Because what happens is a lot of people will experiment with these stronger concentrates and then they will often think, well, if I can, use this stronger, and I have a dab rig or however they're doing it, a lot of people, the percentage of use that is concentrates will increase over time. And so that's a dangerous trend. And so that's a person that I would worry about ending up in the ER for psychosis or hyperemesis. So, but your point is well taken that it's hard to predict where things are going.
It's
You would
just
not have yeah,
yeah,
you
no,
wouldn't
it's
have
just the
predicted
old,
this.
exactly. It's just the old man's approach. So this will really seem ridiculous to you. But when I was in the Yale emergency room and naloxone was introduced, we had no patients to give it to. But the early days when DuPont made naloxone, the principal market for it was anesthesiologists intraoperatively. So
Sure.
that there was no emergency room market. We would have to go get it from them to even give it to somebody. And the overdoses were few and they weren't as extreme. I can't remember what the exact data for usage was, but it was almost approved as an orphan drug
Wow.
because there was so few overdoses. And now here we are in the fentanyl era, and when you say these things from the 70s, it just doesn't even seem possible. So I'm just bringing it up that cocaine in coca tea or cocaine leaf chewing has nothing to do with crack or intravenous cocaine use. And
Mhm.
I'd say for cannabis, we're in a brave new world.
Yeah, no, I totally agree. And I think it's a concerning world, right? And I think that's why we need to educate people about the potential harms and also the potential benefits where they're thinking about using it. But we also have to have better science, right? We need
Right.
the science to continue to advance. And yeah, it's hard to predict where things will go.
Well, I just really want to thank you again for multiple contributions to the field, multiple contributions to how I think about cannabis, for teaching me so much about various things that have happened since uh, my own work on secondhand cannabis. I mean, we actually helped show that secondhand cannabis was firsthand cannabis, but you didn't give consent. And you've really led this field, and I expect you'll do it for another 30 years. Thank
Thanks,
you
Mark.
so
No,
much.
thanks for having me, Mark. I could never teach you as much as you've taught me. So, I thank you for that, and I'm happy just to try to give back just a little bit.
Thanks again.
Thanks.